so we're talking about the pulse, and I just want to go back a few slides. So our heart is like a pump, right? And our blood vessels are like our plumbing system, right? But there's also an electrical component to our body. So we talked about this slide where there's an impulse that starts up in the right atria, and then that creates a contraction, and then it travels, and then the ventricles contract. Okay, so there's a cycle of contraction and relaxation. And when your patient is on telemetry or they get an EKG, this is the image that is printed out that we see. So as an everyday staff nurse on your regular med-surg units, pretty much all of your patients are hooked up to telemetry. They have the 5 stickers, the leads, and then the little devices in the pocket of their gown. Pretty much everybody has it. So every 4 hours, the RN, which is you, is responsible to print out a strip and to analyze it. So they measure, like the little blocks are measuring points, and they measure certain parts of this image and this rhythm, and then they would notify the provider if there's anything abnormal or any changes in this rhythm. So what you're seeing here, so each complex, this is a 6 section strip, which is 1 minute. So for each complex, you can see it would be like 10, 20, 30, 40, 50, 60, 70. So just looking at this strip, the 6-second strip, or 60-second strip, I'm sorry, you can see their heart rate is about 70, okay? Because in this area, there's 7 of those. So what you're looking at there, this first little section right here, that's called the P wave. So it's at the beginning of each contraction. You see that little hump there, that P wave. And what that is the electrical impulse moving from here through here. So it's moving through the atria. Okay, so that's a picture of your heart contracting. Okay, so that's a picture of the atria contracting. This, the QRS complex, it goes up and down and up again here in the middle. That is a picture of the ventricles contracting. So it's a picture of the impulse moving through your ventricles. Okay, so obviously it's bigger. It's a lot bigger because it's a lot stronger. That area of the heart muscle is a lot bigger. That's what pumps the blood out through your aorta, through the rest of your body. So that's much bigger. Okay, so contraction, contraction. This last part, the T wave that you see, is a picture of repolarization. So the electrical impulse like settling back so that it can get ready to strike again. So it's repolarizing or like resting. So setting back to its resting potential. The atria does that too, but it's hidden because it's happening at the same time that your ventricles contract. This impulse is much stronger, so you see this, the atria resetting to get ready to strike again is hidden. So that's what you're looking at when you look at a telemetry strip or look at the monitor. It's the atria and the ventricle contracting and then resetting again. Okay, so you should always see it like this, atria, then ventricles, and then resetting. So you'll see different variations of this. If you have a patient who has atrial fibrillation, which we talked about yesterday a little bit, it's one of the most common causes for an irregular pulse. So when you go to listen to that apical or feel that pulse, it should be nice and regular, about 70, right, give or take between 60 and 100. But if they're just sitting, resting, it shouldn't be closer to 100, it should be closer to 60. So it should be nice and regular and strong. If they have AFib, there's gonna be pauses, there's gonna be jumps, it's gonna be irregular. And what this image would look like is typically the QRS, the ventricles map out pretty evenly usually, but you'll see random P waves all over the place, more than one or missing a P wave, so the atria are erratic and not beating in tune with the ventricle. Okay, so that kind of helps bring it all together, hopefully. All right, so that's that electrical image. Oh, I didn't see that. parasympathetic mode, you're in rest and digest, and vital signs should be stable and normal. And if you're stressed or in sympathetic or fight or flight mode, you have stress hormones that are released, that your blood composition is gonna change, and then those chemoreceptors are gonna notice that, and the pulse is gonna pick up, the respiratory rate's gonna pick up, and then usually blood pressure goes up along with that. Okay, again, we talked about this. These are the coronary arteries. So we talk about the job of the heart being a pump itself, is cycling blood through. It goes through the right atria, right ventricle, then it goes to the lungs where the oxygenation and diffusion occurs. There's that exchange between O2 and CO2. Then it comes back to the left atria, left ventricle, and comes up out the aorta through the whole body. Okay, but the heart, that muscle itself has to be perfused, has to be oxygenated. So we have all these what are called coronary arteries that diffuse off and feed the heart muscle itself, oxygen, nutrients, all those things. All right, so as we're taking our pulse and our apical, some abnormalities that we might find. So I just talked about AFib, which is a dysrhythmia or arrhythmia. It just means that it's an abnormal or just not in rhythm. It's an arrhythmia. Anything besides normal sinus rhythm, that nice, regular, even pattern. Okay, so those electrical signals that I was just talking about, they don't flow like they're supposed to. Maybe they go the wrong way or they're blocked. When this happens, that heartbeat's gonna be too fast, too slow, just not regular, and then we're decreasing our cardiac output that we talked about. So we figured out the stroke volume and the heart rate. We multiply that together, it gives us our cardiac output. If we're too fast, too slow, or erratic, our cardiac output is gonna go down. So we're gonna see dizziness, weakness, maybe confusion, maybe chest pain. When we're gonna see that, so we've been talking about high blood pressure, how that constant rate of high blood pressure is just causing damage to the vessels and then to the organs themselves. Heart disease is gonna be damage to those coronary arteries. And then electrolyte imbalance is a common one. So our electrolytes also serve as kind of like hormones, like chemical signals. Okay, and if those balances are off, it can result in tachycardia or bradycardia, and then we can have a dysrhythmia. Our main, most important electrolyte that we're always worried about is potassium, right? Potassium chloride. Okay, that main treatment for high blood pressure, that diuretic that we've been talking about, Lasix or furosemide, its main side effect is depletion of potassium. Okay, because that drug tells your kidneys, gather up all the potassium, gather up the sodium, gather up the chloride, and release it, get it out of your body. The fluid in your body is gonna follow it, okay, so then the blood pressure goes down. So we know that, we want that to happen, but as a side effect, we can deplete that potassium. Okay, so our potassium should be between 3.5 and 5.1. So that's part of a normal daily lab in the hospital. Your patient will have their potassium checked every day, just like their red count and their white count and their platelets. Every day it'll be checked. Nursing home, not so much. Just depends on what's going on with that patient. Okay, so we're always watching that and assessing for that. So potassium is a common medication that we're gonna then give to our patient as we're just watching for those side effects. It comes in big pills, it comes in oral liquid, it comes in IV drip. Never ever comes in IV push. You could kill your patient if you push IV potassium. Okay, so drip or pills. You're up over there, Hannah. Okay, and then those symptoms, like I had said, dizziness, palpitations is when like they can feel their heart beating. Some people can be really in tune with their body, but you shouldn't really necessarily feel your heart beating. And it definitely shouldn't be uncomfortable or painful or like a fluttery or pounding feeling. So a lot of this is subjective. We would be asking our patient, we're checking their heart rate and we see that it's really high or really low or it's abnormal. And so we're not just gonna call it a day because we're not the aide anymore, we're the nurse. So we're gonna gather more information, collect more data. Are you dizzy at all? Are you having any chest pain? Are you feeling okay? All right, and then their blood pressure pressure could go low depending on what kind of rhythm they're in. And then the weakness, and then maybe even fainting if they're trying to get up and do some things, some ADLs or IADLs while they've got this arrhythmia. Some people don't realize they have an arrhythmia until maybe they have a fall at home. And then they end up in the hospital for that reason, and then they end up finding out, oh, you're in AFib. All right, another alteration that you might see abnormal pulse is myocardial ischemia, or MI, and that's just the medical way of saying a heart attack. So that image of all of those coronary arteries that supply the heart, if one or more of those were blocked off, usually from poor diet, sedentary lifestyle, smoking, drinking. There's a buildup of plaque or narrowing or hardening of those arteries. And so whichever part of that muscle that artery supplied is not getting the oxygen, not getting the blood, so it gets very painful, and they'll have that chest pain, and they'll eventually maybe even lose the function of the part of that muscle. Okay, so they'll go to the hospital, they'll give them an EKG, and the cardiologist can read that EKG, and it can show them that there's a blockage at some point when they read it. So from there, if there is a blockage, then they'll take that patient directly to the cardiac cath unit, which patients can get that and stay overnight, or they can have that scheduled and come one and leave the same day and have a cardiac cath done. So they'll go to this unit, they'll be prepped. They used to always enter their vascular system through the femoral artery in the groin, but a lot of times now they use the wrist. They've figured out how to do that, and it's less risk for infection. So they'll thread into their vascular system and thread all the way through those coronary arteries. And then there'll be a screen above that patient. They'll inject some radioactive dye, and then that'll flood through, and then they'll be watching on the screen at the same time. And all of those coronary arteries in that picture, you should see them light up. You should see that dye flowing through. But wherever the location is that there's a blockage, it'll stop. It won't go through. So then they'll know where to go. They'll thread their equipment in, a stent, and they'll open up that area. Sometimes they'll leave a stent in. Sometimes the stents they leave in have like blood thinning medications on them to prevent more plaque from building up. And so they have that intervention done. They pull out their equipment, and then that patient would have a pressure bandage on that site for several hours. They're not supposed to get up. There are frequent vital signs. So there's some post-procedure care that goes with that. So once we get into the hospital, it's likely that you'll have a patient who maybe at some point during their stay had one or will have one. If your patient goes for that during clinical, you'll get to go with them and watch that procedure and see all of that. So that's what they do for a myocardial ischemia or heart attack. So that would be an intervention if there's an actual blockage, and then medications as well. So blood thinning medications to control their heart rate and blood pressure. Usually cholesterol medications as well for that. Atherosclerosis is just the term for the buildup of like the fatty plaque in our vascular system from diet, smoking, alcohol, sedentary lifestyle. Does everybody know what a sedentary lifestyle is? Sedentary, so just not active, so not getting the daily activity. All right, and then those symptoms, like I said a little bit earlier, I mentioned some of these, but if they are having a heart attack, there'll be shortness of breath, like they feel like they can't breathe. They'll have that pain. It's usually described as a crushing pain. It's usually in their chest, but can radiate to one side or the other, to their neck, to their back. They'll have anxiety, a feeling of impending doom, some nausea, vomiting maybe, and then a lot of times just like an upset stomach feeling. All right, angina is like pre-MI, so they're having this chest pain, but there's no actual blockage yet. Maybe there's some plaque buildup, maybe there's some narrowing, but nothing enough to like really show up or create a blockage to where they're gonna be doing intervention. Okay, so angina is chest pain. It's a sign of heart disease. Okay, so it's kind of like a warning sign. Once your patient has had an MI, they can often have episodes of angina. Once your patient has had MI and had a stent or different intervention, they usually have a PRN bottle of nitroglycerin, and it's a sublingual tablet that dissolves under their tongue. It's a vasodilator, so it dilates those coronary arteries so that they can get oxygenated and hopefully helps with that angina. So they'll have that at home. The instructions for nitro are you can take it every 5 minutes up to 3 times, but they have to watch their blood pressure each time because it's causing vasodilation, and you can bottom out their blood pressure and cause them to pass out. So if they tolerate it, we can give it up to 3 times if they're still having chest pain. But like if we give it once and their blood pressure is like 82/50, we can't give it again. We have to kind of hold tight and wait for the doctor and think of what else we're gonna do. Okay. Angina or chest pain is an emergency event. So like if you're in the hospital and your patient has chest pain, or once you're on your own, you have multiple patients. If you have one who has chest pain, that's a drop everything, go to that patient. Now that's where we're at until the situation is resolved. There's usually specific flow sheets that you can open up that guide your documentation as you navigate a patient with chest pain. But part of it is those vitals, any medications that you're giving, if you're notifying the doctor. Usually we have an EKG come and be done. So all of that would have to be documented. So the end result is either we resolve the chest pain, or the patient is transferred to the ICU for like more critical care drips and closer watching, or they're transferred directly to the cardiac cath unit if we're like, oh, it's going down right now and they're having a heart attack. Okay, but for anytime there's chest pain, that's where we go. We have to follow through until it's resolved one way or the other. All right, and then heart failure is a chronic condition. So once the patient has heart failure, they always have it. You'll see different versions of this. You might see CHF, which is congestive heart failure. You might see readings that differentiate between left-sided and right-sided heart failure. That's all fine and good, but for now at least, like just understand heart failure. It's basically the same across the board. The signs and symptoms are a little bit different if the left versus right side is failing. Because if you think of the left side failing, it's gonna back up to your lungs and you'll see more respiratory signs and symptoms. If the right side is failing, it backs up more to your peripheral, your body, and you'll see more like swelling. What are the chances a patient's gonna have one side and not the other side? So you really don't see that. I mean, once they have heart failure, they pretty much just have it across the board. They have all those signs and symptoms. But like we've been saying all along, there's damage either from the coronary artery disease, myocardial ischemia, or hypertension over time. It's just gonna damage that muscle, the heart, that pump muscle. So it's just not gonna be able to do its job efficiently. Sometimes it'll get like enlarged and just have all this enlarged, not usable cardiac tissue that's just inefficient. So there's not enough room for those chambers to fill up with blood. Those chambers aren't gonna fill or eject efficiently, resulting in that reduced cardiac output that we've been talking about. Remember, that's a high priority nursing diagnosis after airway and breathing. It's circulation. And all it takes is for our patient to have a history of hypertension or coronary artery disease, and we can determine that they have decreased cardiac output. So that's something we need to be thinking about. And then because of that, there could be a backup then, like I just said, of the fluid, of the blood, right, in the heart and or lungs, or in your lower extremities, upper extremities. Okay, the causes then, like I mentioned, and then what you're gonna see in that patient. Okay, so these patients will be on a boatload of medications forever to manage the heart failure, blood thinners most likely, because as you can just imagine from this situation, there's a higher risk of the blood sloshing and sitting around in there and coagulating and kind of clotting together because it's not moving through efficiently. So usually they'll be on some type of blood thinner, like Coumadin is a common one, Plavix is a common one, or that aspirin like we talked about, maybe. Medications to control their blood pressure and heart rate, and then that one that was in our Kahoot, that digoxin medication, it slows down and increases the strength of the heartbeat. Okay, so they'll be on all kinds of medications. All right, so blood pressure then, our last vital signs topic. So there's our normals up here. So systolic is the top number, diastolic is the bottom number. Okay, so top should be normal is 90 to 119. Bottom normal is 60 to 79. Okay, if it's below that, will be hypotensive, or above that will be hypertensive. Okay, what blood pressure is the force of that blood moving against all the arterial walls in our body. Systolic then is gonna be the highest pressure, it's during ventricular contraction. So every time our ventricles contract, our blood pressure is at highest, that whatever the top number is. Okay, so if the patient's blood pressure is 150 over 90, with each heartbeat, the highest it is 150. So if your heart beats, 75 times a minute, every minute you're blasting at 150 through your eyes and your brain and your kidneys and your liver and all of those sensitive organs, you're blasting so high. And then if the bottom number is 90, that's as low as it ever gets for your vascular system and your atria and your ventricles to have a break and to relax. Okay, so that's what's going on continuously with hypertension. If it's lower than that, we've talked a little bit before how blood carries oxygen and nutrients, and then it carries away CO2 and waste. So if our numbers are not high enough, we're not adequately perfusing and oxygenating our body. So there's going to be the dizziness, the weakness, and that also can end in organ damage eventually. Okay, we talked about that. Pulse pressure. So with pulse, we talked about pulse deficit. You guys remember what pulse deficit is, right? So it's a difference between if we have two nurses at the same time, I listen to the apical and Anna checks the radial. If those numbers are off, usually it's the radial would be lower, and all of those beats are not perfusing. Okay, in our Kahoot question, just for easy math, the pulse deficit was 11. That's extreme. You're not gonna see a pulse deficit of 11. It's gonna be like 2, 3, 4. It's not gonna be anything crazy. Okay. Pulse pressure is just the difference between the top and the bottom number. So like a normal 120 over 80, the pulse pressure would be 40. Okay, it's just for now, it's just vocab for you to know. We, in med-surg and nursing home, we really don't do anything with the pulse pressure. Your critical care ICU patients who have all the wires and tubes hooked up to them, they'll have internal blood pressure monitoring devices like in their vascular system, so they keep an eye on pulse pressure to determine like how their organs are functioning in critical care. But for you guys, it's just a vocab word, difference between the top and the bottom. Okay, we talked about what cardiac output is. Okay, cardiac output and peripheral resistance determine the top and the bottom numbers. Right, peripheral resistance just means like the quality and integrity of our vascular system. So if we're smoking, drinking, poor diet, sedentary lifestyle, our vascular system is not gonna be nice and elastic and intact and able to accommodate our blood pressure. It's gonna be stiff, there's gonna be plaque building up, so we're gonna have more resistance coming back. All right, what percentage of the patient's arm should the BP cuff encircle? Yeah, 80%. That's important to get a good blood pressure and choose the right equipment. Okay, this is just a little explanation then of what's going on with blood pressure. So like I mentioned earlier, our arterioles, so our blood leaves our left ventricle, then goes to the aorta, and then it goes through our arteries. Arterioles are like the tiniest little parts of the arteries, right? And then they turn around and turn into venules, and then they're veins, right? So that's where the vascular system flips around from going away from the heart to coming back to the heart. So arterioles are the tiniest little ones that are delivering that oxygen, the nutrients, all of that to our organs and our tissues. So they offer a little bit of resistance when they're nice and healthy and elastic, so that the blood pressure isn't just like squirting in random areas, it's a continuous flow. Okay, and then the elasticity of those walls, in addition to the resistance, helps maintain that normal blood pressure. Okay, so it's not too low, not too high. So over time, with aging or with chronic diseases, if we lose that, you'll see those patients who have that orthostatic hypotension, who when they go to change position, everything drops, because they lose that elasticity of their vascular system to help maintain that pressure. lifestyle, it could also lead to high blood pressure, just overall, because of the, what's the word, the opposite of elasticity. So they're just stiff, unable to give those vessels. All right, and then hypertension then, baseline is gonna be above that 120/80, and then there's different stages above that. A lot of people in the US have high blood pressure, about half people have it. It's a major risk factor for heart disease, like we've been talking about all along. It's the most important risk factor associated with stroke. So what stroke is either a bleed or a clot in the brain. But either way, there's a block of the flow of oxygenation, so that brain tissue isn't getting oxygen, so whatever it was in charge of doing can no longer do anymore. So smile or stick out your tongue, all those things that we do to test for a stroke, squeeze my fingers, all of that. There's usually a deficit on one side or both if it's severe. So over time, if that blood pressure is just blasting and blasting, it can blast through the vessels in your brain and you can have a bleed. So that area, instead of having oxygen flow to the tissues, there's just blood filling in the space. Okay, so they'd be having a stroke. The other type of stroke is a clot. So if they always have high blood pressure, they're causing damage also to the lining of the vessels. So you'll have little pieces that can tear away, turn into a clot. So if you have little pieces that settle in one of your vessels in your brain, that's a clot type of a stroke. So again, it's blocking the oxygen, so then you'll see those signs and symptoms. It's a silent killer because for the most part, you can't really tell when your blood pressure is high until it's getting like really, really high. You might have a headache or hear like pounding in your ears, but aside from that, there's really not signs or symptoms until it's getting too bad. Okay, and then again, this is just reminding what's going on when we do have that high blood pressure, the changes that are happening in our vascular system, and then those vessels supply these important organs, so then there'll be some damage to these as well. Okay, again, just telling you what's going on with that high blood pressure. It's going to cause thickening of the myocardium, which is the tissue. I'll just have to yell now. Sorry about that. So the myocardium is the heart muscle tissue. So it thickens, but not in a good way, not in like a good strong muscle. It thickens in like useless extra tissue. It's just taking up extra space where it could be filling with blood. It's just this enlarged tissue. Okay, so in the muscle itself, in the ventricles, can lead to the heart failure like we talked about. What's myocardial infarction?
Heart attack.
That's a heart attack. Cerebrovascular accident, what's that?
Stroke.
Yeah, that's the stroke, or CVA, that's the stroke we're talking about, and then kidney damage as well. Okay, risk factors we've been saying all along is diet, sedentary lifestyle, alcohol, and then also type 2 diabetes in the family, obesity. Okay. So medications, you guys already have heard diuretics lots of times, so that's usually the first go-to when we're thinking about medications for high blood pressure, are diuretics. And our diuretic that we've been talking about is what?
Lasix.
Is Lasix. Lasix or furosemide. Have a marker? No, I'll write it down later. Okay, Lasix or furosemide is the main diuretic. And then we get into antihypertensives. So we can just say, like in general, there's a class. So as we learn medications, we learn them by class. So we don't have to learn every single drug. We learn the different classes, and then the drugs in those classes have same or similar effects and side effects. Okay, so it's easier to learn it that way. So there's an overarching class called antihypertensives, but then it also has these subclasses. And these drugs work in different ways that we'll talk about more this semester. So like a vasodilator, that's the easiest one to understand because it works like just like it sounds like. It dilates your vessels, And if your vessels are more dilated, then the pressure is gonna drop down. Okay, so for that, if we gave a patient a vasodilator, we would have to educate about changing position slowly, maybe look for dizziness, because we can tell that that's gonna be a common side effect for that one. The other ones we'll get more into as we go through the material, but they just work in different ways to drop your blood pressure. Usually they also will affect your pulse as well. Okay, so if your patient's getting a medication like these once or twice a day, there's at least a couple times that you're checking their pulse, checking their blood pressure, just to make sure that they're safe to get those medications. Okay, and then our hypotension is gonna be too low. Okay, so our body loses that mechanism to maintain or return blood pressure back to normal. Extreme heart failure is one common reason that we'll see low blood pressure. A main one is a side effect of too many medications that we're giving. So we either in the hospital, us giving too much without monitoring, or more likely a patient at home who's got like a medication schedule that they follow, but maybe they're really sick one day and they're not eating as well, or they like threw up or something, but they still take all these medications, not checking, and so they would bottom themselves out. Okay, other reasons would be hemorrhage, which is bleeding, right, or dehydration. So those are our common reasons that we're gonna see low blood pressure in our patients. So for low blood pressure, a lot of times if it's medications that we're giving, we're gonna stop those medications and then maybe adjust in the future. And then we're usually giving some fluids, oral as much as they can tolerate, and then usually some IV fluids to get their blood pressure back up. Okay, again, whenever we have those abnormal vitals, we're gonna note those and investigate that, but we always wanna see if they're symptomatic as well. So the dizziness, confusion, blurred vision, nausea, we always wanna ask for if we do have those low numbers. And then here's a little just summary of what the orthostatic hypotension is. So that's when their blood pressure drops when they change position. Sometimes if you have a patient who's admitted for syncope, which is dizziness, or a fall at home, maybe they'll have an order specifically that you have to check orthostatic blood pressure. So some of you may have done them before, and it's just to see if they're positive. So usually we start with them lying, get a blood pressure and pulse, have them sit up, wait a few minutes, get a blood pressure and pulse, have them stand up, wait a few minutes, get a blood pressure and pulse. And if they're positive for orthostatic hypotension, the blood pressure drops as they go up in position, and the pulse goes up to try to compensate for that blood pressure dropping. It could be something that they always have. Some people take a medication for orthostatic hypotension and it causes vasoconstriction. I've seen patients who take medication for orthostatic hypotension and also take medications for hypertension at the same time. Medications are weird. It's like I said before, it's best to just advocate for lifestyle, diet, and avoid medications when possible. But you'll have patients who take so many, 10, 20, 30 medications at a time. So it could be like a chronic thing that they're always dealing with, or it could be acute. Like if they're dehydrated or really sick, maybe they just have some temporary orthostatic. Okay, and then again, maybe you have a patient who you go through all of that and they feel fine, or you may have one who can barely participate in it because they're dizzy throughout the whole thing. Okay, most important thing is to know that it can lead to falls. Okay, because if their blood pressure is dropping, they're not getting oxygenation, so they can get dizzy and pass out. Okay, so interventions then for low blood pressure or the orthostatic low blood pressure, we're always, with all of our patients, gonna change position slowly just to prevent falls and dizziness. And we wanna take it in steps, so we wouldn't just say, just jump out of bed. We would raise the head of their bed a little bit first, give them a second, and then dangling is just having them sit at the edge of the bed so they can like collect their equilibrium. Hydration is always gonna help if they are dealing with low blood pressure, and then just being aware of what medications they're taking and what side effects to worry about. All right, and then our equipment. So here's what you guys are doing right now. You're practicing your manual blood pressure. That's like the first difficult thing you have to do. The hardest part is releasing that valve to begin with, right? You gotta get it going and then stop and then then you can get your rhythm going. So next week is check off on that. What else? There's a stethoscope. Here's a wrist cuff and then a electronic blood pressure arm cuff. You'll see these in the nursing home. Okay, and then this is what we have in lab, and then you'll see those in the hospital as well. Okay, in our hospitals, once we get in there, all the patients have these disposable BP cuffs, and they're strapped around the patient's hospital bed. So we leave those in the room, and then we just take the equipment in and out. Make sure it's clean in between patients. All right, and then just review of some terminology. So the sounds that you hear are the Korsakoff sounds. We're using the brachial artery. If we have one that's usually higher than the other, use that one that's the higher to get that number. Some reasons that you wouldn't be able to check a blood pressure on somebody's arm if there's an IV line going through it. It just depends, like if they have an IV down here and there's nothing running through it, it's just like hemlocked, then you could get a blood pressure up here. If there's something going right here and there's fluids going through it, you don't wanna get your blood pressure on this side. But just be aware of IV lines. Sometimes that'll prohibit us from using one arm. And then an AV fistula is an arteriovenous fistula. That's for dialysis. So our kidney failure patients. So that is just like a pulsating mass of vessels under their arm. It could be upper, it could be lower. And that is their lifeline. So 3 times a week they get hooked up and they get needles put in there and they get all their blood taken out and cleaned out and then put back in. So we would never do blood pressure on a side that they have a fistula. And then if they had a mastectomy on one side, we usually wouldn't do that one either because usually they take lymph nodes and so now they're at a higher risk for infection. And so we worry about causing trauma or damage to that side. Okay, so some indications. So if you're ever doing a whole new admit, that would be part of your questions, your admission assessment. But otherwise, those would be things that should be passed down and report to you. And a lot of facilities have like signs above your patient's bed that say, you know, only left arm blood pressure or whatever it is. The popliteal artery, a few times I've had to do a leg blood pressure if there's like amputations and different things going on. So the popliteal artery is the back of the knee. So you would put that cuff on their upper leg and then put your stethoscope on that popliteal artery. Sometimes we have to use the radial artery. So it's best to just have the equipment that you need for your patients. But if we don't have a cuff that's big enough for their upper arm, then we can do lower arm and use the radial artery to get a blood pressure. Okay, and then a Doppler ultrasound. Did you guys mess with these in the lab? Yes, very good. Okay, so it's just a handheld ultrasound. We'll have to see if the nursing home has them, but all hospital units have it because if we're trying to do our head-to-toe assessment and they have weak pulses, we can use that to find their pulses really well. So that's a handheld Doppler. And then this would be like in your critical care unit, an arterial line. So this would be an invasive line that they can determine blood pressure through. So that would be critical care. All right, and then that's just another image of our vascular system for when we're thinking about blood pressure. All right. All right, in your groups, I have a little activity for you guys to do, and this is over vitals. 5 questions, little scenario and 5 questions. So you guys can work on that, and then we'll share what you come up with. And then we'll get into documentation. And then I was gonna bring up the calendar and show you guys. So today's Wednesday. Tuesday next week, we're doing head-to-toe assessment. And then that's the last study guide and PowerPoint content for exam 2. But then we still have 2 more days of lecture before exam 2. We have the Wednesday, and then we have next Tuesday. So we'll be doing like activities and review questions and stuff. So we'll be going back over everything and putting it all together and making sure that you feel comfortable with the content. And then I'll be having a practice exam available also for exam 2.
I probably will.
Alright, did everybody get one? So we'll just give you a few minutes to do this, and then we'll share your answers, and then we'll take our break.
Yeah.
Anytime they say they're you basically just had to it's like at the top of that.
It says right here, I've been feeling a little awkward because I didn't so. So that's subject.
Yeah.
What is the likely connection between vital signs and her admitted diagnosis of UTI?
Right, that's what I'm saying. The temperature will change.
Oh, yeah. I would say so. Because malnutrition and dehydration usually make it go down.
I'm not even
With heart rate.
What? I said I'm not a nurse.
I think you're right. Temperature. Some elevation shows infection.
Yeah. She's already been diagnosed, they need to
So probably putting a bag of
IV fluid, antibiotics.
That's what I would say, but are we allowed to say that because we're not